I'm Dr. Stephen Harris, Professor of Pharmacology and Physiology and Associate Dean for Academic Affairs at the Kentucky College of Osteopathic Medicine. I will be teaching pharmacology, and our Pharmacology Section 1 lectures begin with general principles. Chapter 1 is going to deal with pharmacokinetics. This diagram shows us the relationship between pharmacokinetics and pharmacodynamics. These are terms that you need to be familiar with. And the first thing that you should do is you should come up with a definition for each of these terms. I believe in simple definitions, so let's come up with a simple definition for pharmacokinetics. Pharmacokinetics is what the body does to the drug. So remember, what the body does to the drug is pharmacokinetics. On the other hand, pharmacodynamics is what the drug does to the body. Obviously, these two terms are interrelated. When we look at this diagram, what I would challenge you to do is to look at which parts of this figure represent pharmacokinetics and which part represent pharmacodynamics. We can administer drugs, and there are a lot of different ways to do that. Drugs get absorbed into the plasma. They can be distributed to tissues. Sometimes they can be bound up in the plasma, or they can be bound up in tissue storage sites. Drugs are metabolized. We know the liver is the main organ for drug metabolism, but it's not the only organ. Other organs can contribute, of course, to drug metabolism. And drugs are excreted, where the kidneys are the primary organ, but once again, not the only organ. If you stop and reflect on those four things, absorption, distribution, metabolism, and excretion, those are all things that the body is doing to the drug. So those are our four parts of pharmacokinetics: absorption, distribution, metabolism, and excretion. I will tell you that on your Step 1 exam, very, very few questions will deal strictly with pharmacokinetics. That means more often than not, questions on your Step 1 exam are going to deal with pharmacodynamics. The part of this diagram that deals with pharmacodynamics is shown on the right side here, where the drug interacts with its receptor. And the two most popular pharmacodynamics questions are mechanism of action and side effects. Mechanisms of drugs are tested heavily on Step 1 exam. They're tested a little bit less on Step 2 and Step 3, but side effects get tested really across the steps. So when I look at this picture, remember the relationship between kinetics and dynamics. First, we're going to talk about the concept of drug permeation. When you think about permeation, permeation is really the ability of a drug to move effectively in the body. There are certain factors that are really, really important for determining drug movement. The two most important of these are lipid solubility and concentration gradient. Lipid solubility, most drugs are designed to be lipid soluble so that they can move easily within the body. And concentration gradient, because most drugs are going to move passively down their concentration gradient. So these two factors are really the most important determinants of drug movement. But other factors can contribute, things like surface area and vascularity. If you take surface area, for example, if you imagine taking a drug orally, you compare the absorption of that drug from the stomach versus the small intestine. And if you think based solely on surface area, the small intestine, of course, has a much larger surface area. So if you're thinking of surface area, the small intestine is where drugs are more likely to be absorbed compared to the stomach. When it comes to vascularity, if you think about different types of administrations, an intramuscular injection compared to a subcutaneous injection, for example, the intramuscular injection is obviously going to be absorbed faster into the body because muscles are more vascular compared to fat. So the subcutaneous route is going to be a slower route compared to IM. Our next topic is ionization. Ionization is very, very critical for you to understand for your Step 1 exam. When you think about the topic or the concept of ionization, you have to remember that most drugs are weak acids or weak bases. Probably at least 80% of all drugs fall into this category. And what that means is that drugs can exist in two forms. They can either be non-ionized or they can be ionized. You should remember that the non-ionized form of the drug, that is the uncharged form of the drug, whereas the ionized form is the charged form. And predicting how much of each form is going to exist depends on knowing two other things, and that is the pH of the environment and the drug's pKa. You don't have to worry about remembering specific pKa's for drugs. If the exam wants you to do anything with pKa, they will tell you what the pKa is for a particular drug. You probably should be familiar with certain pHs. We'll discuss that on a later slide. Remember that the concept of pKa is defined as the pH at which the molecule is 50% ionized and 50% non-ionized. It's also important to remember that only the non-ionized form of the drug, the uncharged form, is the only form that really can effectively cross membranes. On the other hand, the ionized form is really more likely to be renally excreted. Because ionized drugs can't cross membranes effectively, they're more likely to be eliminated. If you look in the margin, there's a note called "in a nutshell." It reminds us about those weak acids and weak bases. It reminds us that the ionized form is water-soluble. That's why it's more readily eliminated. The non-ionized form is more lipid-soluble. That's why it easily crosses membranes. That's why that's the form that's going to stay in the body longer. The notes that I have at the bottom of this slide talk about some very important weak acids and weak bases. These are drugs that I will discuss along the way during the lectures. Some of these are going to be drugs that you already remember what type of drug they are. If I look at the list of weak acids, for example, don't you already see one of these drugs that you recognize? The first drug there, aspirin, acetyl salicylic acid. Most people already remember that that drug is a weak acid, but it's also important to remember that loops and thiazides, very, very popular diuretics, are also weak acids. When it comes to weak bases, local anesthetics are weak bases. I think there's a mechanism of action question waiting for you on step 1 related to local anesthetics. I'll say it this way. In order to describe the mechanism of action of a local anesthetic, you have to understand the concept of ionization, so watch out for those. Then I also notice amphetamines and PCP. PCP, phencyclidine. PCP, also known as angel dust, both of those drugs, PCP and amphetamines, are drugs that potentially can be abused. So knowing that they're weak bases gives you an advantage on the exam, perhaps as it relates to being able to eliminate those drugs. In order to effectively describe the concept of ionization, this slide is critical. When I look at the relationship between a weak acid and a weak base and the different forms that are going to exist. First, start with the weak acid. Notice the two forms of the weak acid. On the left, you see RCOOH. Basically, that would be a carboxyl group with a hydrogen attached to it. Notice that that form has no charge, therefore you would call it non-ionized, and that's the form that will easily cross membranes. On the right side, we see RCOO-. We see a negatively charged molecule. That, of course, is the ionized form. It's water-soluble, and that form of the drug is going to be better cleared. Now, the next thing that I'm going to say depends on how comfortable you are with your chemistry. If you love chemistry, if you love talking about carboxyl groups, then that's fine. On the other hand, I actually strongly suggest that you simply remember an easier way to diagram out what's going on with a weak acid. On the left, I would write this as HA. So the H, of course, stands for the hydrogen, and the A could be your acid drug. So HA would be an acid drug with a hydrogen attached to it. Notice that form has no charge. That is your non-ionized form. And on the right, instead of writing a carboxyl group with a negative charge, how about just thinking of it as an A, an acid drug with a negative charge, and the hydrogen has been removed. You can do the same thing with a weak base. On the left side of the diagram, you could go with RNH3+, a positively charged base. That's the ionized form that's better cleared. Another way to write that would be to write BH+. Again, B for base with a hydrogen attached to it has a positive charge, so it's ionized. On the right side, RNH2 would be your non-ionized base. You could also write that as B, simply the letter B for base, again with the hydrogen removed. Now you have to write these in the order as they're written. On the left side, you have to write the drug with a hydrogen attached to it. And on the right side of the diagram, you have to write it with the hydrogen being removed. This is very critical to your understanding of this concept, because I want you to think about this, that if I were to draw a line right down the middle of this diagram, right through the arrows, that really could represent the drug's pKa. What I'm saying is, if the pKa is right in the middle of this diagram, when I put an acid or a base into a pH that's lower than the drug's pKa, those drugs are going to have hydrogens attached to them. So if it's an acid, it's going to be HA. If it's a base, it's going to be BH+ at lower pHs. Because what do you find at low pHs? you find lots of hydrogens. On the other hand, the right side of the diagram would represent pHs that are above the drug's pKa. When you get greater than the drug's pKa, the pH, you're going to see that the hydrogens are removed. The hydrogens get removed from the acid or the base, leaving you with either A- or B. So the left side of the diagram becomes more acidic. The right side of the diagram is more basic or alkaline in relation to the drug's pKa. A final note on this slide. The term protonated is sometimes used in test questions. Obviously, a hydrogen is a proton. If I say, what does a protonated acid look like? A protonated acid is going to be on the left side of my picture here, HA. A deprotonated acid, A-. A protonated base, BH+. A deprotonated base would be B, the non-ionized form. So you have to really draw this diagram out. Think about it in order to answer these questions and not mess up this concept, because you can sometimes try to do this too fast. If I say, is a deprotonated acid going to effectively cross membranes? You have to think to yourself, a deprotonated acid is A-. That's ionized. That form will not effectively cross membranes. That form will be better cleared from the body. So be very careful with this concept. So here's our first graph. I would tell you that this might be the most challenging graph that we have to deal with in all of pharmacology. So that's very exciting that we get to deal with this here in the very first chapter of section 1. It's a graph that has an x-axis and 2 y-axes. So that makes it challenging from the start. You've got 2 y-axes here. In fact, if you look at the x-axis actually has a calculation on it. That's exciting as well. Some of you are thinking, I'll just skip this one and move on to the next graph. So if you're graphophobic, let me make sure that you understand. Always look at what your axes are showing you. The x-axis here shows us pH minus pKa. 2 terms that I think we have to know anyway. 2 numbers that they're probably going to give you in a test question, but 2 numbers I'm sure that you can work with. For example, if I do a calculation of pH minus pKa and I get a negative number, what does that mean? If I get a negative number, by the way, never live in abstract land. Always come up with a concrete example. So pick a pH, let's say a pH of 4 and a pKa of 6. If I did 4 minus 6 and I get negative 2, what does that mean? Obviously it means that the pH was lower than the drug's pKa. So the left side of my x-axis is going to be the acidic side, where the pHs are lower than the drug's pKa. The right side of my x-axis, if I did a calculation, let's say the pH was 7 and the drug's pKa was 5. If I do 7 minus 5 and I get a positive 2, that means the pH is greater than the drug's pKa. So the right side of my x-axis is a basic environment. Once again, those terms, acidic and basic, are relevant to the drug's pKa. That's what our reference point is. It's acidic or basic in relation to the drug's pKa. The graph shows you 2 lines, one for a weak acid and one for a weak base. You should be able to predict what form of the weak acid is going to exist in an acidic versus a basic environment. So if I start at the top left of this graph, if I put a weak acid into an acidic environment, acidic environments have lots of hydrogens, so I'm going to have a hydrogen attached to the drug. It's going to be in the HA form. The major form of the weak acid, the lower the pH, in fact, the more HA I'm going to have. But what is happening as I move left to right on this graph? If you follow your x-axis from the left side over to the right, what is changing in the graph? It's not the drug's pKa because that's a constant. What's changing is the pH is going up. So what is going to happen as the pH goes up? As I get a higher and higher pH, more of the hydrogens start to be removed from the drugs. So the HA form is going to start turning into the A- form. The far right side of my graph, where I've got a much higher pH, hydrogens have been removed, and the drug is primarily going to be A-. So I go from a state on the far left, where I'm highly non-ionized, HA, to on the far right, where I'm highly ionized, because the pH has gone up and the hydrogens have been removed. If you look right in the center of this graph, what does it mean when pH minus pKa equals 0? Obviously, that means that pH and pKa are the same, and therefore you're going to have a 50-50 relationship. 50% of the drug is ionized and 50% is non-ionized. You can do the same thing for the weak base. The bottom left corner, you put a weak base into an acidic environment. You're going to have lots of hydrogens there. The hydrogens attached to the drug, it's going to be BH+ in a low pH environment. It's highly ionized when you take a weak base and put it into a low pH, into an acidic environment. As I move left to right, we know the pH is going up. As the pH goes up, the hydrogens are removed from the weak base, turning what was a highly ionized drug now into a highly non-ionized drug on the far right side. So the weak base in the B form is going to be easily absorbed. It's highly non-ionized. If I look on the far right of the graph, on the far right I see the other y-axis that shows renal clearance of the drug. Notice that the arrow is going down. Make sure you don't miss this. The arrow is going down. So the forms of the drug that are more likely to be cleared are found at the bottom of this graph. And those forms, of course, A- and BH+, those are the ionized forms of the drug. It's the ionized forms that are more likely to be cleared from the body. At the top of the graph, the HA form and the B form are non-ionized. Those are forms that are going to stay in the body. Next, we want to look at how ionization increases the renal clearance of drugs. There are several points to remember about renal clearance. When it comes to the glomerulus, remember, only free, unbound drugs are filtered. In other words, drugs that are bound to plasma proteins are too large to be filtered at the glomerulus. Once again, you're thinking about normal renal function at this point. Watch out for the second bullet point. Both ionized and non-ionized forms of the drugs are filtered. This is the part that folks will miss. They will think about the concept that we've previously discussed, that ionized drugs don't effectively cross membranes, and that is true. But when it comes to the glomerulus is actually permeable even to ionized drugs. So hang on to that thought, and we'll see it in the diagram on the next slide. It's the non-ionized form of the drug, however, that undergoes secretion and reabsorption, because those are processes that involve crossing membranes. And once you're inside the renal tubules, all the rules apply again about ionization, which is the non-ionized form can cross the membrane, the ionized form cannot. In fact, the ionized drug is what's going to be trapped in the filtrate, and this is where, if we can manipulate the pH of the urine, we can influence drug elimination. The figure here does a very good job of explaining the points that we just covered. So when I look at the glomerulus, who's going to be filtered? Free drug, but that drug can either be ionized or non-ionized. Remember, both forms can get into the renal tubules, but once they get into the renal tubules, only the non-ionized form can now cross the membrane. Once you're in the proximal tubule, for example, I can see active secretion of a drug, but it's in the non-ionized form. If you wanted to kind of summarize what you know about the glomerulus and drug filtration, here's a way to summarize that. I would say that the glomerulus is a good size filter. It's going to discriminate based on size. In other words, a drug bound to a plasma protein, that size is too large to be filtered. So therefore, the drug has to dissociate from the plasma protein to its free form. That's what's going to get filtered. But isn't it true that the glomerulus is a poor charge filter? It really doesn't discriminate based on charge, because we see that both the ionized and the non-ionized forms will get filtered. So let's talk about how ionization can affect the renal clearance of drugs, and specifically focus on ways to manipulate the pH of the urine. Think about it. Why would I ever acidify the urine? Well, I would acidify the urine to enhance the elimination of a weak base. Somebody overdoses on a weak base. Let's come up with some examples. My clinical vignette, CV stands for clinical vignette, would be patient overdoses on either amphetamines or PCP. You remember that those are weak bases. Neither of those drugs has a specific antidote. So what's a strategy that you can use to facilitate their elimination? You could take advantage of the fact that you understand ionization. You could acidify the urine. You can take a weak base drug and you can make it ionized. You can take that base and convert it to BH+, and you'll eliminate amphetamines or PCP. You can do the same thing if somebody overdoses on aspirin. Again, aspirin, a drug that does not have a specific antidote. So what's a strategy you can use to facilitate the elimination of aspirin? You can alkalinize the urine. Once again, by raising the pH of the urine, you're going to take that weak acid drug, you're converting it into A-. A- is your ionized form. The ionized form is more readily eliminated. So urinary alkalinization. In the margin, there's a clinical correlate that tells us exactly how we could do this. How do you change urinary pH to acidify the urine? You could use a compound like ammonium chloride. NH4Cl can be used on patients who overdose on amphetamines or PCP. You can acidify the urine with NH4Cl. On the other hand, what would be something you would use in aspirin overdose? You could use sodium bicarbonate. Sodium bicarb will alkalinize the urine. You can use this strategy to facilitate the elimination of aspirin. A very, very popular question on the test. I mean, why do folks overdose on aspirin? And the answer is because they can. Because they can easily access aspirin. So aspirin overdose is such a popular thing on the test. Here's a way to apply ionization principles to that scenario. If you look in the bottom right corner of my slide, here's what I call a bacterial clinical vignette. It really doesn't have anything specifically to do with drug overdose. What it's got to do with the fact that certain bacteria can change the pH of the urine. You've learned this in micro, that organisms like Proteus and ureaplasma, those are organisms that can alkalinize the urine. If you think about the action of those bacteria, they raise the pH of the urine. And for example, if you get a patient with a UTI and the urine is alkalinized, Proteus could be a causative organism there. So we can manipulate the pH of the urine, obviously with drugs, to our benefit for a patient who has a drug overdose. But we also think about what other things like bacteria can do to the pH of the urine. So I imagine that I'm you on test day, and I get a question on ionization. What do you do? Obviously, what you can do is you can actively write something related to ionization. I'm going to show you a diagram that you can use very effectively to answer really any type of ionization question. The first thing that I want you to do is remember that normal urine pH is in a range of about 5 to 8. That's a typical normal range, 5 to 8. Then, when I get that ionization question, first thing I do is I draw a pH scale. I draw that scale 0 to 14. As I read the question, somewhere in the question it's going to mention the drug's pKa. Let's say the pKa in the question was 5. I draw a line representing 5. When I draw that line, do you see what I've done? I've divided my pH scale into two parts. The first part, the pH is all lower than the pKa. That's on the left side of the picture. The second part, pHs that are above the pKa. Those are my two compartments. Now, answer this question. If this drug was a weak acid, what form of that weak acid is primarily going to exist on the left side of this figure? If I put an acid into an acid environment, I'm going to have hydrogens attached to it, so it's going to be HA. On the right side, that's going to be your more basic environment. If I put an acid drug into a basic environment, it's going to be A-. The hydrogens are going to be removed. Just for argument's sake, what if this was a weak base? With the same pKa value, let's just go with that. If it was a weak base, then it would be BH+ on the left side. Hydrogens at the low pH environment are going to be attached to the drug. On the right side, it's going to be B, where the higher pHs, the hydrogens have been removed. So can you draw this diagram? Sure you can. You can draw this diagram and you can use this to answer questions related to ionization. Let me give you a couple of those now. For example, if a patient here is taking a weak acid drug, do you think this weak acid drug with a pKa of 5 is going to be better absorbed in the stomach or the small intestine? Based on its pKa, is it better absorbed in the stomach or the small intestine? Well, what's the major form of this drug in the stomach? It's HA. The stomach, very low pH, around 1 or 2. But in the small intestine, which has a quite a bit higher pH, the drug is more likely to be in its A- form. So which of those forms easily crosses membranes? HA. The weak acid drug is better absorbed in the stomach. What about weak bases? Forget pKa for a second. Is a weak base better absorbed in the stomach or small intestine? The answer has to be small intestine, because the small intestine has a higher pH. So there's a greater chance of having the drug in the B, in the non-ionized form. That's the form that will easily cross membrane. So a simple rule for you is this. If I want to keep the drug in the body, I put that drug in its like environment. If I want to keep an acid, I put it into an acidic environment. It will stay in the body. If I want to keep a base, I put it into a more basic environment. It will stay in the body because it easily crosses membranes. But what do I do with those drugs if I want to eliminate them? I put them in their opposite environment. How do I eliminate a weak acid? I put it into a basic environment. I want to increase urine pH. So if somebody overdoses on aspirin, what would be a goal for you to raise urine pH to? If you look at the normal range, maybe getting the pH up to around 8. The higher end of the normal range would have that drug in its ionized form and more easily eliminated. On the other hand, what if I want to get rid of a weak base? You want to get rid of amphetamines? Acidify the urine. Put it into its opposite environment. Make the urine pH closer to 5. You're going to readily eliminate that drug because it's in the BH plus form. If you look in the margin on the bottom corner of page 4, you see this clinical correlate that talks about using the drug lactulose. Now, if you remember the use of lactulose, it can be used to treat hepatic encephalopathy. If you get the question on your test, what drug is useful in treating a patient with hepatic encephalopathy? That's fantastic. Right? The what question is always easier to deal with. What drug do you use for hepatic encephalopathy? The harder question to answer is why. Why do you use lactulose to treat hepatic encephalopathy? So let me give you this clinical vignette. First of all, you have to be able to recognize the patient, because sometimes they're just not going to tell you that it's hepatic encephalopathy. Characteristics of this patient: they're going to have increase in their liver function test, they're going to have increased blood ammonia, they're going to have an enlarged abdomen, and all of that would help you to recognize, hey, that's hepatic encephalopathy. You remember that you can use the drug lactulose to treat this condition. But do you remember why? It's because lactulose is metabolized by gut bacteria into lactic acid. This is why this is related to the concept of ionization. I'm basically converting lactulose into an acid, and when I do that, I am acidifying the intestinal tract. When I acidify the gut, what's going to happen is I'm going to convert ammonia into ammonium. NH3 becomes NH4+, positively charged. I'm going to add a hydrogen because, again, low pH environment, hydrogens are readily available. When I convert ammonia into ammonium, I can readily eliminate ammonium, and that's the way to lower blood ammonia. That's the rationale behind using lactulose as a treatment for hepatic encephalopathy. When you couple that with the fact that it's also a laxative, it's going to increase GI motility. That can also facilitate elimination. Next, we're going to talk about drug transport across a membrane. When you look at this diagram, there are really three basic mechanisms for drug transport: passive diffusion, facilitated diffusion, and active transport. But when I look at the different columns here, the two that I want you to always link together, the carrier column and the saturable column. See, these two columns go together because a system that uses a carrier can be saturated. So what's a characteristic of passive diffusion? Passive diffusion does not need a carrier, therefore it's not saturable. And that's really critical. Obviously, it doesn't need energy either, but it's not saturable. And I think that's the first question you want to answer. When I see that question on the exam, and I'm asked to determine what type of transport is taking place for a particular drug, the first question I want to answer, is the system saturable? Because if the answer is no, I didn't saturate it, we know that it's passive diffusion. Here's what the question might do. They will give a certain concentration of the drug, and that will produce a certain amount of movement. They will increase the concentration of the drug, you'll get more movement. They increase it again, you get more movement. If they continue to do that, and you always get more movement, you are not saturating the system, therefore that is passive diffusion. On the other hand, if I increase and get movement, increase, get movement, and then I increase again and I get no further movement, what does that mean? That means the system has been saturated. Now I've got two choices. It's either facilitated diffusion or active transport, because both of those utilize a carrier and can be saturated. Now I've got to answer question number 2. Does that system use energy? Because facilitated diffusion does not, active transport does. Here's what they will do in the test question. Many times they will use an inhibitor of ATP production. If I use an inhibitor of ATP production and it has no effect on drug movement, then that obviously is facilitated diffusion. I didn't need energy, I didn't need ATP. But if I use an inhibitor of ATP production and it stops drug movement, then that is a system that required ATP. You would conclude that is active transport. That's your way to determine the type of drug movement that's going on.